So now that you've heard a little bit about the details of the model from Nick and Gabrielle, I will spend some time talking to you about participation in the model and the nuts and bolts of how you can become a primary care first participant. So first, I want to talk a little bit about the practice eligibility requirements for primary care first. And to be clear, these are the requirements for the option 1 or the general track of primary care first. So what you see on the screen are the eligibility requirements. I'll run through them quickly for you. So all primary care practitioners within the practice must be in good standing with CMS. And a primary care practitioner for purposes of primary care first is an MD, DO, CNS, NP, or a PA. Additionally, practices must have a minimum of 125 attributed Medicare beneficiaries. All practitioners within the practice must collectively bill at least 70% primary care services. You'll be able to get more information about what we mean by primary care services or how we define primary care services once the RFA is available to you later this spring. Practices in primary care first must also be able to demonstrate prior experience with value-based care and value-based payment arrangements. Practices must use the 2015 edition of Certified Electronic Health Record Technology and support data exchange with other providers and health systems. And additionally must meet a limited set of advanced primary care delivery capabilities, including providing 24/7 access to a practitioner or nurse call line, and also impaneling patients to a practitioner or care team. So those are the eligibility requirements for the general PCF track. I'll turn now to the eligibility requirements for those practices interested in serving a high needs population or taking SIP-identified beneficiaries. I will note before I run through these that any practice who wants to do option 3 or participate in both the general track and the SIP track needs to meet all of the eligibility requirements on both of these slides. So in order to accept assignment of SIP beneficiaries in primary care first, all practitioners who serve SIP patients also in the practice must be in good standing with CMS. Additionally, practices must be able to demonstrate that they have the capability to manage complex patients, which includes using an interdisciplinary team-based care approach and also providing person-centered comprehensive primary care. Practices also must demonstrate the ability to engage with patients as well as their families and caregivers, and also must provide 24/7 access to a practitioner or nurse call line. In primary care first, CMS is committed to partnering with commercial payers, Medicare Advantage plans, and state Medicaid agencies to provide participating practices with aligned payment and aligned support. We aim to partner with payers in the 26 primary care first regions that provide or will provide an aligned partial alternative to fee-for-service payment. Multi-payer payment alignment should also enhance the performance-based incentive opportunity, which is already present for CMS payments in the model, and will motivate practices participating to provide the best care for their entire patient population. CMS also highly values alignment with other payers in other areas, such as sharing aligned data with practices, both at the participant and practice level, on cost, utilization, and quality. We will work with the primary care first payer partners to align on practice quality and performance measurement, and to broaden support for seriously ill populations, especially for those not covered by Medicare. So now I'm going to talk a little bit about the benefits of participation in primary care first. So your practice will see many benefits from participating in primary care first. First, the model will allow you to spend more time with patients and deliver the care your patients need by increasing flexibility and reducing the administrative burden associated with revenue cycle management. There's also a significant opportunity to increase your revenue in this model. As Nick noted earlier, you can increase your revenue by up to 50% by participating and performing well in primary care first. Primary Care First also will provide robust, actionable, and timely data that will allow you to measure performance on both the practice and individual practitioner level. We've also honed focus to a single outcome measure so you can focus directly on keeping your patients healthy and out of the hospital. We're really excited about this opportunity to bring in and provide enhanced support for practices who care for chronic complex patients and for seriously ill populations. And finally, though not yet set in stone, our aim is for Primary Care First to qualify as an advanced APM. Now I'm going to talk a little bit about the next steps and how you might apply to participate in Primary Care First. Primary Care First announcement in April kicked off a series of activities to prepare for a successful model launch. Practice application and payer solicitation will occur beginning later this spring and through the summer. During this time, practices who wish to participate can respond to a request for applications, which will be posted on the CMS website, and CMS will solicit payer partnerships separately. In late summer and into the fall, we will select participants and payers for Primary Care First based on the eligibility criteria I just discussed a few slides back. Primary Care First will officially launch in January of 2020, and we will have a quarter of ramp up, and the payment changes will begin for participants in April of 2020. So between January and April, you'll do a lot of onboarding to CMS systems, get familiar with the data that will be provided to you, and basically begin to learn all about how to participate in the model. When the RFA is available later this spring, we encourage you to read it and determine whether Primary Care First is right for your practice or your organization. And we'll have many resources available for you to learn more about the model and spend time reading about the details, which I will show you on a slide in a couple of slides. We'll also provide information on how you can join our listserv or access other Primary Care First resources at the end of this webcast. We'll now take a minute to answer your questions and provide some answers.
Great, thanks, Leah. This is Gabrielle Schechter, co-lead of Primary Care First again, and we're excited to answer your terrific questions. I'm joined in the room by Nick Minter, Cyan Goldson-Desabay, and Brian Walderson, and we're all here ready to answer your questions, and I will kick it off. The first question relates to the timeline and wanting a little bit more information about that. And so I'll give you what we have right now, and we'll be sure to provide more information about specific dates as those become available. So when will the applications be available online? We really are looking towards the spring. Stay tuned to the website, which we update frequently, and it'll have a link to our online portal once it is opened. And you'll have around between a month and 2 months to respond to that application. Each application will be at the practice level, and we have streamlined the application. If you have experience with CPC Plus as a reference point, we've streamlined the application significantly, so hope that it will be pretty straightforward for you to respond to, but we, of course, are always available to answer your questions. And then a question about when will a practice be notified if they've been accepted into the model. So, you know, it'll take us a couple months to evaluate and assess all of the applications that we've received. So do expect that in the fall is when you would be hearing back about your acceptance. So thanks for that good question. So now Nick.
Great, thank you, Gabrielle. So we received a couple questions about how the monthly payments in the model will affect other sort of infrastructure in Medicare, in particular the secondary insurance payments or Medigap payments. And understanding that the monthly payment consists of two different components, the population-based payment and the flat visit fee. I'll sort of address each one quickly. The population-based payment, we do not, there is not a planned copayment for that particular payment, so we see limited or no impact on secondary insurance payments. from that standpoint, the flat visit fee will be subject to the standard 20% Part B copayment requirement. We are looking into providing the availability, if you will, of copayment waivers for practices that wish to use those for patients that have a need for that, but we will have much more information about that in the coming weeks and months. So.
Hello, everyone. This is Diane Golson-Desabay. I have a couple questions here related to the quality strategy for the model. A few people are asking about the measures that we are actually using. 3 of the measures are ECQMs. We also have the CAPS, and we have the acute hospitalization utilization measure. With regards to the definitions for these measures, more information on the ECQMs can be located on the Quality Payment Program website, and the definition for the acute hospitalization utilization measure can be located on the National Committee of Quality Assurance website as well. And I'll hand it over to Brian.
Thank you, Cyan. I had a couple questions here on the PCF high needs model. First, someone asked if the 10% downside, 50% upside payment also applied to SIP participants. And no, that is specific to the PCF general model. The PCF high needs model has a $50 geographically adjusted up and down adjustment. It might be easier to think about an 18% up or down on the $275 monthly payment. Next, how will SIP providers enroll patients? The main mechanism will be through an outreach connector organization, which will identify and attribute beneficiaries to practices in selected zip codes. More information on this will be forthcoming. I should mention here that there will also be a SIP-specific or PCF high needs specific webinar upcoming in the next several weeks. So we look forward to giving you that. What happens, the next question, what happens after 12 months for patients in the SIP program? After 12 months, we would expect practices to take them on as a normal primary care patient if enrolled in the PCF general model. If not, they will need to transition to another primary care practice. Finally, on the quality payment, is that per visit, annually, or monthly? And that would be a monthly, it's a monthly $50 adjusted, paid quarterly. And then I had one question here on overlaps, in particular the overlapping with the MSSP ACOs. They will be eligible to overlap, and any beneficiary identifiable payments will just need to be included in the aggregate payments for the ACO when comparing to the benchmark. Okay, passing it back to Gabrielle.
Okay, thanks, Brian. So we have some questions around how were the regions selected to begin in 2020, those 26 regions that we announced earlier, and then looking forward, how will they be selected, any prospective other regions. And so the regions, those 26 regions were primarily driven by an effort to be sure that we have the sufficient information to evaluate the comprehensive primary care plus model, which many of you, it looked like, are currently a part of. And so we know that primary care interventions take some time to see results, and we're deeply committed to comprehensive primary care plus. And so we wanted to make sure that we had adequate data to assess that model. And so the 26 regions selected were those that had the minimal impact on that ongoing evaluation. So that was primarily how those regions were selected. And we'll think about going forward, should we select other regions in future years? We'll be looking at stakeholder interest in those regions, and also, so if you're interested in participating and you are not located in one of those 26 regions, I see someone from Georgia, for example, tuning in, do let us know that you're interested. Email us. We're taking tabs of who's interested, and so appreciate that. Thanks very much. Okay, Nick?
Sure. Thank you very much, Gabrielle. There are a few questions here on the risk adjustment model in primary care first and whether or not social determinants of health are included. And, so what I will say on this particular line of questioning is that the model is using the HCC risk adjustment model for the purposes of stratifying risk, if you will, or classifying practices according to different risk tiers. We, are always looking for innovative ways to stratify risk in the future, but for this model at this time, we will be using the current HCC model and all the attributes factored into that.
This is Cyan again. So I have a couple questions here related to reporting. We have reduced your reporting burden by reducing the number of measures that you are currently going to report on for this model. The reporting is annually for this, and the benchmarks that we will be using for reporting will depend on the measure, but it's between MIP, our merit-based incentive payment program benchmarks, as well as reference populations. The reference populations can be either within the model or without the model, as outside the model as well with a control group. So that is for the reporting, and I have one more question related to the data. Data will be made available to the practices in Q1 of 2020. And I'll hand it back over to Gabrielle.
Thanks, Diane. So we have gotten a number of questions about whether Fqhcs or federally qualified health centers are eligible to participate in primary care first. And the answer to that is no. And that's primarily because the way that federally qualified health centers are paid differs from what we are innovating upon in this model, which is the traditional Medicare fee-for-service, and federally qualified health centers are paid differently and through a different payment system than the physician fee schedule often. So that is really what we're innovating on in this model. Of course, we're always looking at ways to innovate in the federally qualified health center space. So if you are a stakeholder in that area and have interest, we always recommend that you submit those ideas to the PTAC, which is an advisory committee that looks at Medicare models. So definitely look into that if you're interested and have ideas. Okay, Nick?
Sure. There are a few questions about how the population-based payment is calculated and whether or not it's calculated at the member or the practice level. Just to quickly provide a sort of overview here, unlike CPC Plus, which did calculate the CPC payments in Track 2 at the member level, in primary care first, we are going to assess an average, or determine, I should say, an average HCC score for the practice, and then based on that score, we will determine the population-based payment to be paid, which will be the same for every attributed member in a practice for the time period that is applicable. I will also note that we plan to reassess the sort of categorization of a practice by risk score annually. So we understand that patient panels and profiles change over time and are working to accommodate that.
This is Gabrielle again. I have some questions related to some of the eligibility criteria that we discussed earlier. So precisely what we mean by having experience with value-based payments. And so we really have sort of a broad definition for that. It's whether a practice has experience with payment that is somewhat tied in some way to cost, utilization, and or quality. So those could include shared savings arrangements. Those could include other performance-based incentive payments. And another experience that would be certainly count in this area is an alternative to fee-for-service payment, so some kind of partial or full capitation, for example. We do have kind of broad definitions for that. And To be clear, that experience could include a participation in such an arrangement with CMS or with partner payers. It's really just some readiness to accept the kinds of financial model that we're describing in this presentation. Nick?
Sure. A couple questions I want to address here. So we have, there are some questions about how vaccines and procedures that are performed in a primary care office would be paid out in the primary care first model. Primary care first pays sort of these model payments that we've discussed for codes that are generally performed in primary care offices, but those are really around care management, E&M codes, et cetera. For vaccines and procedures that are more episodic and sort of not in the bundle that is also in CPC Plus as a good reference point, those will be paid out in the physician fee schedule still. So in other words, for vaccines and procedures, your billing pattern and path will not change in this model. The second question I wanted to address is the 10% downward adjustment discussed in the performance-based adjustment part of our presentation cumulative? In other words, does it sort of compound over time? The answer to that question is no. To think about it one way is, if a practice is making $100, and I admit this is clearly a simplistic example, and they receive the 10% downward adjustment due to performance or not meeting quality gateway, the next quarter that payment would be adjusted to be $90. If that happens in the following quarter, it would still be $90. We will not continue to take 10% off of that payment. The same is true for the upside. The base remains the same, and the performance-based adjustment is applied newly each and every quarter that the performance-based adjustment is assessed.
Okay, so unfortunately our time together is so short. We're coming to the end now, and this is our last question. But before I get to the last question, I just want to put a plug in for going to keeping up to date with Primary Care First by always looking at our website. Also, if you are interested in in getting emails from us, sign up for our listserv. So please do keep informed, and if you have any questions, always reach out to our email inbox, which we'll be showing in just another slide. So our last question is an important one, and is how is this model being defined? Is it at the TIN level? And this model is at the practice level. If you have experience with Comprehensive Primary Care Plus or the Comprehensive Primary Care Initiative before it, it's really defined by the practice site. Another way of thinking about that is the bricks and mortar practice location where patients are seen. Of course, if you're a home-based practice, that might look different for you. And if you have any questions about that, please do get in touch about. But that's the way that the program and the model is run, and also how we're going to be assessing applications. So thanks as always for your great questions.
So we'd like to know now what Track 3 related topics you're interested in learning more about in future events and materials. So please indicate whether you would like more information on payments, quality measures, comprehensive primary care interventions, reporting and data sharing, or another topic. If you select Other, feel free to enter the specific topic in the Q&A field on your screen. Thank you for responding. We will use this information to guide future Primary Care First activities. We appreciate your attendance and questions during today's webcast. To learn more, visit our website, subscribe to our listserv, email questions to our mailbox, or attend upcoming events. You can also follow us on Twitter at CMS Innovates for updates on this model and other models supported by CMMI. Please provide your feedback on today's session to help improve future Primary Care First events. A post-event survey will appear in a pop-up window on your screen in a moment. Thank you for your attention and interest in Primary Care First.
That concludes today's presentation. As a reminder, materials from today's presentation will be available on the CMS website at a later date. Thank you for your participation, and feel free to now disconnect.